morning, everyone. Welcome to sunny Miami. My name is Aziz Assatius. I'm the interim chair for the Department of Informatics and Health Data Science and founding director of the Media and Innovation Lab at the University of Miami Miller School of Medicine. Let me just share with you briefly the vision of our department. Our department, as we call it, is the department of the future. Reason being is because how we are set up organizationally and operationally looks more like a startup or a scale-up as opposed to an academic institution, because we believe in our bold vision of reimagining academic medicine and the role that academic schools and departments play in this new dawn of innovation and technology in healthcare. And how we are doing that is by actually trying to reimagine healthcare across 5 core verticals. We're trying to do it in education, where we're creating next-gen med curricula to train the providers, clinicians, scientists, and practitioners of the future. We're doing it in research, we're doing it in clinical care, we're doing it in venture and service outreach policy and ethics. And so with that bold vision requires the process of developing a culture and a community of innovation. And our Future of Health Data Innovation webinar series is one such activity where we bring together not only our University of Miami community, but our wider and our global community to be able to do this. I am just so delighted that we are joined by another phenomenal speaker, Dr. Alexander Brost. He is head of clinical innovation and concepts at Siemens Healthineers, as well as digital and automation. And he leads a several strategic initiatives on AI and clinical innovation. He has over 15 years of experience spanning research and product management and innovation leadership. He's played critical roles in translating cutting-edge technologies into impactful healthcare solutions. His career, which is quite well decorated, includes several roles in product management as well as innovation and project leadership, particularly in electrophysiology and imaging and other forms of device technologies. And we know that most of you here are here to hear him speak about how AI can revolutionize radiology. And it's not just radiology, it's image recognition and detection. And so with that, please join me in welcoming Dr. Brost. Before he starts, I want to ask and want to thank my colleagues, Alex and LaRonda, as well as Dr. Mairead Maloney, who have done amazing work in putting this all together. And I know Alex has a few updates for you. Go ahead, please, Alex.
Thank you, Dr. Assatius, for that introduction. And we're all excited, I know, to see Dr. Brost talk. I'm really looking forward to it. So I wanted to highlight that we at the Department of Informatics have a couple of other talks coming up in this series, and I will post this in the chat. We will be having a talk from Dr. Catherine Brown from Vanderbilt University, and she'll be giving a talk on AI in U.S. rural healthcare. So a very interesting topic, and that will be happening at the same time on Thursday,
Thank you,
November 20th.
Thank you.
And then the other talk that I want to highlight is that we'll be having, we're also launching a FemTech program here at our department, and we'll be having a talk, some FemTech Fridays talks. The next one is November 14th. I'll put that information in the chat for all of you. Thank you, and I will give it back to you, Dr. Assatius.
Well, thank you, Alex. Dr. Brost. So as you can see, I hope you feel like you are now part of this growing ecosystem and family. We have almost 80 people here just to see you, my friend. So I am getting my popcorns ready to feast on just an amazing presentation. I turn it over to you, my friend, and welcome to everyone.
Thank you very much. Hello to everyone. I feel humbled to actually have the opportunity to speak to you and share what's in my mind, but also in the mind of my colleagues that work with me, and to really discuss and also at the end with you what do you all think about how AI will change our everyday life? So yes, it's not only radiology, even though I will focus on it. But first, a few disclaimers. Okay, you can already judge from the slides. I'm fully employed by Siemens Healthineers AG. And to give you a few more disclaimers, I cannot predict the future. I would really love to, but I have not yet found anyone who can really do with an absolute certainty. Some concepts that I will show here are not products, and they may never will end up as a product. So keep this a little bit in mind. I open a little bit the door, what we are working on, to also show you what might come down the road. And also, I used AI, of course, a little bit to generate this presentation, mostly some of these images, but you'll recognize them. So I work for what we call digital and automation. And before I discuss this imaging value chain, digital automation essentially within Siemens Healthineers is the part that purely focuses on software. AI solutions, PACS, advanced processing, scheduling, cross-collaborative talk, and all this kinds of stuff. So I don't sell MRs, but they use the software that we actually work on. So that's the interesting part. And when we say, okay, imaging value chain, what does it actually mean? Imaging value chain for us is essentially anything on the patient's road through a hospital from his history, because every patient that comes into hospital has a certain history. If he's not at this point born in the hospital, but he already has seen a general practitioner before, and then he gets scheduled to get a scan, images are acquired, then they are processed, then there's the interpretation done, the reporting, and in the end, you also need to communicate certain things to the patient. And that whole thing is what we call the imaging value chain. And the smart part, of course, is adding AI to it. How can we improve? How can we improve the life of the patient, but also ease the workload of the radiologist? Now, a few pictures here. I will take you on a small journey, going back a little bit in history. How has diagnostic radiology been in the past? Where are we right now? And how can this evolve in the future? And in the past, radiology was always like, okay, I get images, I take a look, and I write a report. Now, for the remainder of the talk, I know everybody uses certain words differently. Whenever I talk about radiologist, I'm mostly talking about diagnostic radiologist, even though I also have a background in interventional procedures and working with interventional radiologists. So some people know this either from movies, or you might have seen this in certain hospitals, these glass-shaped things with the light in the back where you can actually really hang pictures. So in the past, they were really printed. And someone really had to go in and hang this for the chief radiologist to look at this in a certain way. When we talk about history, let's take a little bit about the history, certain milestones that we have seen in radiology. Don't worry, I will not read the full list, but you can later, when you watch the recording, pause and take a look. So from really discovery of X-ray, discovery of radiation, clinical ultrasound, PET, CT, MR, there has been a certain development over the years. And I put next to it certain milestones of computer science. So computer science goes a little bit further back. Not in terms of, okay, there has no medicine been before, don't get me wrong, but there has been certain concepts, ideas more from the mathematical perspective. The interesting part is more when it really starts with real computer programs. I would say somewhere in the 50s with Fortran, COBOL, and so on, really start being able to program certain devices. And I would say one big milestone that we should emphasize on was in the 70s when the graphic user interface came up. 1973 was the first when Xerox Alto came up with how a user interface looks like. And you're all either using Mac or Windows or maybe some Linux systems. They all have these graphical user interfaces. And that actually led back to the 80s to developing of the first PACS system, where you can show and see the images that were previously taken by MR and CT, so on. And I put here an older example of the PAC system that we had in the past called Syngoplaza. Some people still use it. And you can see it was then much easier to actually take a look at these images. You didn't need somebody to hang up all these different hanging protocols. You cannot do this basically with a computer. And I think that's when most of the radiology part actually entered into the computer age. So from that to where we are now, why that depressing image at this point? So this was the past, and we are now here because there is already AI out there. I'm not sure how many of you are currently using any kind of artificial intelligence tools. There are tools out there that support specific detection, segmentation, and so on. But at this point, everything goes back to the radiologist. He needs to either confirm or decline the findings that AI has been done, because you don't want anything end up in the medical archive that's actually wrong. So nobody wants to really have that at this point. So hence the depressing. Currently you get more and more information, more and more images to look at, more and more findings. And that's not the only part, because when we take a look a little bit the bigger picture, there's a demographic change, and that results in more patients for you. People are getting older. I'm sitting here in Germany, but sometimes hear these stories that people actually go to Miami to retire, which I can understand. When I've been there, it's nice there. So, but it means you probably get also a bit more older patients. They need to wait in the UK pretty long, 6 to 8 weeks to actually get a scan. Then we have staff shortage. In Germany, it's like 47%. They can't find radiographers. And you can still optimize how the systems are being used to basically increase the patient throughput. This is what we in our overall strategy consider as access to care. How fast as a patient can I get access to a system? So the more scans I can do, let's say per hour, the faster a patient can get a scan done. Now, that's just one part of the equation, because on the other side, somebody needs to take a look at these images and actually make a diagnosis. And it's a rather old study, and people here in this call hopefully can either confirm or deny that that's really the case. But we see more and more that we can't educate enough radiologists to really keep up with the demand. And when you go into literature, you see more and more that this problem is really considered. So there is this publication that comes from Australia. How can we actually measure the workload? I don't want to go too much into detail of the study, but they actually checked how many diagnostic studies were done every month. And you see, by speeding certain tasks up in a hospital, you can increase how many studies are done. And even though the yellow line for X-ray looks like, okay, it's pretty stable, put a line here. No, it's actually increasing. I think X-rays might be one of the modalities that's already pretty fast in terms of throughput, but you can still see, okay, people are still going on to optimizing it. Now, the next part that's more interesting, the number of diagnostic images increased also significantly. And this one peak that you can see in the region here, let me quickly get laser pointer up here. That's actually when they started using thin slice CT, 1 millimeter slices. That, of course, tremendously increased also the number of images that you need to read. So what does this now mean for a radiologist who needs to take a look at all these images? Well, you find publications about burnout everywhere. If you go to PubMed and search for any kind of radiologist, surgeon, and burnout, you will find several publications. And it's also confirmed by the people that I talk to, burnout in radiology is increasingly global. So the RSNA even tackled it. The link is down below. But they said, okay, there are certain cues to do it. Now let's take a look what they proposed. And I don't mean this in a bad way. They said, okay, single sign-on. Remembering passwords, logging in, maybe even different user accounts. Yes, of course, that is a burden. And something that some of us in our private lives, when you have, let's say, something from the same ecosystem, Apple is doing a really good job there. And log in once, everything's available. Something that we missing, but see more and more now coming also in the medical environment with all the different systems that you have. They also listed ergonomic mice and headsets. I know enough people that have issues with their wrists because they were using the mouse too long, too often. Tedious tasks. But that also, of course, if that hurts, it leads to, I don't feel well at work, and then you end up with burnout and everything. And they also listed, quite interestingly, automation of routine and protocol-driven tasks. So keep in mind, we had one at the beginning already. You don't need to have somebody sticking up the film. You can just directly use it in packs, but you still have certain administrative tasks that you need to do. And let's go in and take a direct quote. Automating these kind of tasks, when appropriate, can get radiologists back to what they love, including looking at and interpreting images, taking care of patients, teaching residents, and helping referring providers. Now, at this point, let me ask you a question, and you can put it in the chat. What is it that you really want to do as a radiologist? I don't know how many radiologists we have in the chat. Why am I asking such a maybe stupid question? Well, read the quote. There are certain things that can be automated. And let's take a look what also the industry has done, not only us, but also others. There are AI and machine learning medical devices out there. The graph here actually comes from the FDA, what they have authorized between 1995 and 2023. So you see a significant spike in AI tools that are now available, that can be used to really improve what's done. Is this already solving the whole problem? Probably not. Let's take a little bit, someone made a rather aggressive statement back in 2016. Jeff Hinton said, we should stop training radiologists now. It's just completely obvious that within 5 years, deep learning is going to do a better job than radiologists. At that point, there were some people who believed that this is true, and some people said, okay, that's not going to happen. That was 2016. We are now 2025, and yet he acknowledged his mistake. But he also stated a combination of AI and a radiologist will make radiologists a whole lot more efficient in addition to improving accuracy. So if you were afraid about your jobs, I think that problem is solved. But in the same way, also other people put it, AI will not replace medical professionals. However, those medical professionals that use AI will replace those that don't. And to be honest, in my profession, I have a background more in computer science. Same thing is happening there. So jobs are not lost, but the roles are redefined. And I will come back to that later. So if you don't use AI, you are, of course, at risk of ignoring technology. At the beginning, I'm pretty sure, that was before my time, there were radiologists who refused to use PACS systems. Why? New technology, nobody likes it. People don't really like change. But change is happening, and currently at a pretty fast rate going forward. So AI will change radiology. I think we all see that, and not going to replace radiologists. But there's also a publication out that I will come back to later. Radiologists will become information specialists. So what actually is a radiologist? Don't take it too seriously. someone who does precision guesswork based on unreliable data. Also see magician and wizard. It's also someone who sits in a dark room and looks at grayscale images. So you look at these images, you try to figure out what's wrong with the patient, you write the report. So quick interruption at this point. So before we now talk more and more about radiologists, let's talk a little bit about what is AI and all this stuff. So AI, artificial intelligence. Artificial intelligence is the capability of computational systems to perform tasks that are typically associated with human intelligence, such as learning, reasoning, problem solving, perception, and decision making. Now, some of you are thinking, okay, where does this fit in and so on? But that's the official definition that's used in artificial intelligence, computer science, and so on. You've read a different type as well. What is actually deep learning? Deep learning, more often associated with artificial intelligence. Deep learning uses multi-layered neural networks to simulate the complex decision-making power of the brain. You can see a very rough sketch. So you have different layers and you try to really model a little bit the brain. Interestingly, when I started learning pattern recognition, machine learning, we also had this concept. At that point, honestly, mostly the computational power that we had when I was studying were not yet sufficient to really use this efficiently. Just took too long. The next question, a little bit neural network. Half answered it. It's a machine learning model that stacks simple neurons in layers and learns weights from data. The whole concept goes back to what is called Rosenblatt's perceptron back from 1958. That's when the original idea came up. So you see, it has taken quite a long time until the whole thing came really proficient and effective. So now everybody's talking about AI models. You might have heard the term a couple of times. By definition, an AI model is simply a program that has been trained to recognize patterns or make decisions. So yes, neural networks are AI models. You can just take those, or you can take other AI models, other methods, like a support vector machine. That's what people used before whole neural networks got so much of interest. And then you also all have heard about agentic AI. Agentic AI, it doesn't look like James Bond. By the way, in my opinion, Gemini did a pretty good job in creating this image. Agentic AI is simply an AI system that can perform tasks with minimal supervision. So basically, take an agent, go out, order a pizza, and have it delivered. And you don't really supervise it. You basically give it a task, fulfills it. So coming back to redefining radiologist. Somebody made a publication and said radiologists will become information specialists. Why? Well, radiologists do more than just interpreting images. It's not that you just sit there and look. You integrate this in the whole clinical process. You basically also act, let's say, as a human fail-safe to ensure that AI doesn't go crazy. You all have seen when AI did several mistakes. Some of you know certain stories where Google Maps didn't really do a good job and came up with a very weird route, which took hours longer than you actually needed. So we need somebody to actually sit there and think and have the whole patient context in his or her mind as well. And the other interesting part, whatever we're doing with AI requires labeled data. You can try to work unsupervised with unlabeled data, but at a certain point, you really need to validate the data. So you need radiologists to really check how good it is, because you all in the end want to have a good accuracy when treating patients. So radiologists in the future probably will also need to act as data guardians. And like any other profession, I already said, my profession is changing with AI. Radiologists will also need to evolve. Will it then be called apart from radiologists with AI? I don't know. Let's see. There are also some critical voices who will benefit. There's one publication that I just put here that said, okay, the employed radiologists will not really benefit. But you can also see the curve. There is still enough way to improve in terms of productivity going forward. I don't completely agree with that publication. It's my opinion. And I also believe at this point, we are not nearly close to where we could be with AI tools to really improve the productivity of a radiologist. I talked about the whole big picture of a patient. Let me show you a video, and I hope it comes across well. So you see this, what we sometimes call a galaxy of data. What you see in this short video, I can play it a couple of times if you want, this all is information about one single patient. Let me quickly jump back and play it again. It's just one patient. It was an oncology patient that we got from a collaborative partner that we have in Germany, where they try to visualize how many information they have. And these, let's call it these yellow stars, actually are imaging. The rest are blood values, treatment plans, other information. And all of this needs to be at some point be analyzed and taken into account because every patient is different. And we can't really see this the same way how we develop software for radiology. Here you see an evolution of PACS system. There's now way more information in there. It's not only that the screens got bigger, but also the amount of information that's being presented. You see, for example, also pathology in there. And to take a more detailed look, it's a one workspace that tries to combine a lot of information. I'm not going into all details, but there's also actionable reporting. We have advanced visualization where you need it to, if you want to look at something in 3D, then there's the access to other clinical information, to any kind of EMR system that's available. Also non-DICOM information, maybe also history of the patient. There's also access to innovation and research through a digital marketplace where either we as a company deploy certain prototypes or even other universities deploy prototypes. And of course, the integration of artificial intelligence is also in there. Now, with the help of agentic AI, we can shift from a more passive tool where I need to click, okay, I want to have this algorithm and I want to have this. I can start to perform more autonomous tasks, like dynamically prioritize imaging studies. Imagine that you have somebody that sorts your email inbox by what do you need to answer first? It's a question that we get on a regular basis from radiologists. Can you do that? And to do this on a large scale for the whole work list, that's not a very trivial task. Then to tailor recommendations based on the patient history. Just because somebody has lung cancer doesn't mean that everybody gets the same treatment. Because you have patients, one is a smoker, the other one was a worker that had to deal with asbestos, the other one is a runner. So you have all these different things to keep in mind. Also at a certain point, you need to see, okay, what's the life expectancy of the patient? What are the potential treatment options? Quite simple. If you have a patient that has whatever issues, if the patient is like 16 years old or 80 years old, makes quite an impact because the earlier you catch something, the better, of course, and because life expectancy. Then, of course, automate administrative follow-up tasks. There are certain things where I really hope that I soon will get an additional agentic AI. I'm just mentioning travel reimbursement, where I need to somewhat select the value-added task that I need to pay for whatever ticket that I use when I use the metro in Paris. That's kind of, I don't need that. So giving that to an AI is quite a task I would look forward to. But those are certain things that really can be automated. And it offers potential gains also in the efficiency. You get more information, the information that you need directly at hand. Triage accuracy and cognitive support are also listed. And you find quite a lot of ideas, publications out there, how this can be enabled going forward in the radiology workflow. And you see, it's not everything around the AI agent, of course, that's in this publication, but you see, of course, the radiologist sitting there, and they say prompt query feedback answer. I think this is something, I'll address this on the next slide, that we also need to keep in mind. You don't want to prompt everything. Certain things need to be automated. You want images from the PACS. You want patient history from the EMR. You want to have certain image processing already being done. When the patient is in and he's lung cancer screening, okay, then please detect the nodules, do a lung segmentation, and so on. And potentially also trigger some other AI agents if you already know, okay, we need to start treatment. And the design of these systems becomes more and more important. So how can you design a good AI system? Recent publication, Guidelines for Human AI Interaction, from the University of Washington together with Microsoft. And they picked 18 guidelines how to really develop this, how to design it. I picked 6 of them here, make clear what the system can do. I'm not sure how many of you use certain co-pilots, as they are called, agentic AI and so on. I'm struggling a little bit with a few co-pilots here and there. One like, okay, can you clear out my calendar today from 5 to 6 because I have to give a presentation. I'm not going to join any other meeting. The co-pilot nicely tells me which meetings I would have had, but he doesn't clear it. So it's not really that actionable. So we need to have a little bit more development there. I would have preferred if it told me at the beginning when I prompted co-pilot to do it, but something to keep in mind. Show contextual relevant information, particularly in the medical world. This is really, really important. Support efficient invocation. How can I really do this really, really fast? And speed is something that we need to keep in mind. Make clear why the system did what it did. When you use any form of navigation system, it nicely shows you different routes and gives you one recommendation. And then you can also see, okay, the other one, there's a traffic jam, there's construction going on and so on. So we understand a little bit more. So we need to be able to understand why AI came to certain conclusions. Number 13, learn from user behavior. That's a little bit trickier in the regulated medical world, but also something that we hopefully in the future we will see. Why is the user clicking certain things and then do it automatically? And of course, notify the user about changes. We all know this, and most of us, I don't think, really read it. The app on your phone got updated, you get this nice splash screen. Okay, this has been changed. Okay, fine. But this is also important. If there are updates, for example, accuracy of tumor measurements and so on has improved, you might want to go back and check the old cases because now it starts measuring slightly different. This is also something to keep in mind going forward. Now, as talked a little bit about speed, there is the speed of interaction. And 0.1 second is considered that the user feels that the system is reacting instantaneously. Don't start complaining. Hold on until I'm done with the slide. 1 second is the limit of the user's flow of thought. 10 seconds is the threshold for keeping the user's attention. Now, keep in mind, those numbers, those studies were done in the 90s. If you talk to somebody who uses computer games, I'm pretty sure that 0.1 second, they will already complain about the lag. So this is something that also needs to rework and reevaluate it. So much talking about how to design it, the speed. The other thing to keep in mind, we also need to talk about failures. AI is not perfect. I'll give you a very nice example. The issue that exists, and everyone who's worked scientifically knows this, failures are hard to publish because nobody's interested. You always publish what actually works. But we need to talk more about failure because we need to understand why it failed. And you can't really find really good publications out there, but you find a few websites here and there that list those issues. Known issue, IBM Watson. It proposed ineffective and even dangerous treatments. The Babylon Health chatbot introduced a significant gender bias. The Epix AI sepsis alert system had a lot of misses and false alarms. And then there are enough systems out there that started not using the image content to figure out if a bone is broken or if there's a pneumothorax or anything. They actually use DICOM text and the hospital logos. So something to keep in mind when you talk, for example, with computer scientists and data scientists, because all of this introduces a certain data bias. So something you need to tackle on the algorithmic level and the data that you feed into. And also test it in real life. So you can't just go into a shed, build a nice car, and expect it to work in the rain if you've never tried it. So you need to go out and test it. And that's becoming more and more important to really go out, test it, which is essentially the validation and verification. So, and to keep in mind with AI, there's this nice shield that I see in some coffee kitchens. Drink coffee, you can do stupid things faster with more energy. Now with AI, it's essentially the same. There's this nice publication, artificial intelligence do stupid things faster with more energy. Because the whole thing is moving really, really fast and you can do more stuff. So talking about failures, let's take one example. There was this Thai chatbot. Microsoft developed it and it got pretty famous for sending inflammatory and offensive tweets. Why? Well, the initial data came from books, websites, and articles, and they also included chat forums. If you've ever been into one of these forums, you notice that on page 2 or 3, people started insulting each other. And the chatbot essentially did the same thing. It generated responses based on what they had learned. And it learned that at a certain point, humans get offensive and insult each other, and it basically replicated that. And with that, stepping into the data requirement that we will see coming. For computer scientists, machine learning, that's even worse because we need a strong data governance. We really need to trust in these autonomous decisions. So we need to understand what's really the data behind it, to not introduce any kind of bias. We need structured and transformed data. It sounds a little bit strange, but it needs to be modeled and tested. You can't just arbitrarily throw data at it. So you can't take the same learning process and say, okay, I'll take handwritten paper and then I take CT images. You need to modify it that AI can understand what's doing. The semantic clarity and the consistency, you need clear definitions. And it also needs to be secure, particularly in the medical world. You don't want to have specific tumors then suddenly being disappearing or not. That's a critical part. The data needs to be secure here. And then, of course, you need to have feedback loops and observability. The first versions of ChatGPT was quite famous also for hallucinations. So in the end, keep in mind that if you have bad data, that leads to bad decisions. And with AI, they now happen even much faster. Now, one thing going forward is AI models will use data that you as a radiologist have in your PACS, in your EMR. It uses your annotations and your reports. So keep that in mind. At a certain point, AI might even go in and reanalyze. And there are quite some examples that I'll show later on. And I've at a certain point see Copilot using some of my old emails to actually try to generate replies. It didn't work out that well. You need to be careful what you currently give such an AI tool to work with. So what will come in the future? There are publications, I'll show both of them on the next slide. There's automatic report generation. So as a radiologist, you might not even have to write or dictate your reports. AI could do that for you. There are very early detection of diseases. I brought 2 examples where AI can detect specific hints for diseases very early. And then, of course, precision medicine. So that all hopefully leads to a reduced workload, as AI can potentially also cover certain cases autonomously. So here, two publications, the MIRA 1 and the MIRA 2, about a radiologist doesn't need to write his report. It can be done by AI. You just need to make sure that the findings are correct. And now I hope that the sound works. Alex, I see you.
The results of your scan showed multiple small, potentially calcified pulmonary nodules in both of your lungs. Pulmonary nodules are small, round or oval-shaped growths in the lung. They are often not cause for concern and can be due to previous.
I stopped the video for a second. You don't need to listen to all of it. What we did there is essentially we took a radiology report and translated it for a patient. You've heard a lot of stuff that no radiologist would ever write in a report. But it's quite interesting for a patient to get a simplified version of what's actually going on. You could add more information about what he could potentially do at home to ease pain and everything. That was just one test that we did. The other thing, there's a publication here from McGill, and I'm stepping out a little bit of my competency zone because I have a background in computer science. I work with radiologists, let's put it like that. Here we're going down on a cell level. But with that system, they detected very, very early hidden disease markers in single cells. Mayo did something similar. They linked blood mutations to cancer and heart disease. So in the future, we will probably see certain AIs coming along that can go into the archive that we have in hospitals and detect very early. And this will become an ethical discussion. How are we going to deal with that? Now, I mentioned precision medicine. Precision medicine and the future of personalized healthcare. AI can help to solve the most difficult challenges in precision medicine because it can combine all this information from the symptoms, the history, also from the lifestyle. Because depending on your lifestyle, you might see different diseases more often. Somebody who flies to Brazil on a regular basis is more likely to have malaria than me just traveling Europe and the US, unless these flies make it across, but that's a whole nother story. And then also, you see for certain tests, AI can reach a pretty good level to really support radiologists. So how does the job look like of a radiologist? Well, more information for a radiologist to digest. It still ends up in one report. But there are these AI tools now. You need to confirm and decline. But maybe there's also a way, around the radiologist. If AI is really sure that, for example, the bone is broken, do you as a radiologist still need to do it? Currently, yes, you still need to sign off, but it might in the future be something where you can say, okay, AI has done it. Okay, fine, good. And just showing you one prototype here. This is a way that we currently envision a diagnostic cockpit in the future to allow access to all information in one workplace. You see the history. You can, just by a click query, you don't need to write, okay, what's wrong with your aorta? You can just click there, right? Adrenal gland, the same. And then you get the answer like suspicious, unchanged, remarkable, also with the timestamps. You can propagate lesions, which is quite interesting because AI can measure quite consistently. Now, with that, going in one direction, there's one thing that I just want to add a little bit at the end. It's not only what you work, but it's also where. There's a study that says, okay, work from home for radiologists is not that easy. So you need to have a certain private air conditioning room, ambient light, and so on. And actually only 78% actually meet these requirements. And we played around with what you probably all know, the Apple Vision Pro. And only those two monitors here are real, but it gives you an option to see way more information than you do right now. And I give you one example. So this is just what the Apple Vision Pro can do with their virtual environments. So you currently see me standing on the moon, but I'm actually somewhere hiking. And then you can actually open one of these interfaces, take a look at a scan, And the nice thing is you can also look at the whole thing, not only here in 2D, but you can also look at everything in 3D. Something to keep in mind. So that's one opportunity. The other, when you're actually hiking, you might get a call from someone, say, okay, can you please look at the case? And here you can do it. You can remotely log into your PACS system and take a look. At this point, I would not recommend anybody really using Apple Vision Pro for hiking all the time. It gets quite heavy after a few hours. But here, you can actually get a call on a cell phone and say, okay, I have it with me. I put it up. Maybe hiking is a little bit an exaggeration, but at home, background, service, and so on. And then you can call your colleague. Now, to come to the end of my presentation, so a lot is happening right now, not only in radiology, but also in computer science. So please keep in mind that computer science will also move forward new algorithms, new models, new concepts. Just this paper came out recently, the Dragon Hatchling. It tries even to further improve these neural networks that we talked about. Everything's pretty fast paced right now. Keep in mind that somewhere a computer scientist is writing source code with a co-pilot, and that can go really, really fast. Radiology, like any other job, will need to redefine itself. How does it work with AI? And AI will help you, but you also need to talk a little bit with the computer scientists. What are the tasks that you want to do and not? And we will see in the upcoming years more and more transformation. With that, I would like to thank all of you, particularly the team from the University of Miami. Appreciate it that I could join. And then if there are any further questions that I can't address in the remaining minutes, feel free to reach out to me.
What a wonderful presentation, a tour de force. Thank you, Dr. Brost. Just an amazing presentation. And I was taking so many notes, but as I was taking notes, you said another gem. So I hope I was able to keep up, but just amazing. So again, folks, as Alex mentioned, please drop your questions in our Q&A. I saw a couple of questions both in the live chat as well as the Q&A. So I believe Nan asked the first question, so I would read their question. And it's more of a clarification question, Dr. Brost. They ask, what does the data guardian point mean? They did not fully understand that. So if you could, perhaps spend some time to clarify that, please.
Data guardian here means really you need somebody to make sure that the data you use for AI training is correct. Because you can go out and ask anybody out on the street to highlight a tumor. Is that really the best example? No, you need really to say, okay, yes, that is. And then in the future also, this is a malignant and a benign tumor. So this labeling of the data, that's what I meant with the data guardian. You need to have somebody that really understands what the data means, that AI can use it going forward.
Okay, no, thank you. One of our own faculty, Ravi, asked, would enabled AI in clinic have or provide any hope or scope to eliminate security barriers for increased multi-care provider collaboration where it could benefit all? And so is Siemens receiving requests for collaboration through common treatment planning system engagements?
We have seen several of this, and there is the typical things about silos, as we call it. There's radiology, and then it goes over to cardiology. But you currently see more and more trends around the world to get these people together, to really come up with a concise plan. I think one of the things that I've observed, tumor boards are getting more and more multidisciplinary. I'm pretty sure we will see this in other ways and in other areas as well. So yes, we currently see those requests to break up these silos, to exchange more information, to also provide the tools to other adjoining disciplines.
So I love that, and I'll take the liberty to extend that question, because I had my own questions as well, and I know most of you as clinicians or technologists have this question. So this new move toward digital pathology. Can you highlight what are some barriers and what are some solutions in overcoming that, particularly in the clinical setting?
So in a clinical setting, there are, to me, I'm not a full expert in digital pathology, but happy to recommend a colleague afterwards if you have more detailed questions. We see two things. First, need to understand it's a different type of image, something that you're not used to. So me looking at CT and MR, I'm fine. I understand a little bit of ultrasound. Seeing these cells, I need to really understand, okay, what's in there? What do I see there? And then you already have tools that are maybe a little bit more proficient there when it comes to really cell counting. They are a little bit more advanced. They, I don't know, started earlier or are easier to do, I don't know. But then you also have the sheer volume of data. So if you take a look at how big such a pathology image is, just in terms of screen resolution versus the other one, we're talking about way more different imaging, way more data. We had a customer telling us once that in his image archive, 60% is just digital pathology.
Wow.
MR and CT is like another just 30%. So you have a lot of information there. You need to combine it. So also managing that data server-wise, how to transmit it, how to show it, also becomes increasingly an issue.
No, this is fantastic. And I guess our last question comes to us from Alex. What aspects about AI literacy and computer science are most prudent to be incorporated in the training of radiologists and even beyond that and other clinicians so that they can be prepared for the future? Lovely round out question.
Yes, that's perfect, because I think we need to start even earlier. I think we need to start nowadays in schools. How do we work with? There's always a certain hesitancy to give small children smartphones and so on. I got my first mobile phone when I was like 14, 15. Now you see people first grade already running around with an iPhone. But you need to grow up with it. You need to understand how to ask questions. So how do you nicely prompt that you get a specific result? What are the questions that you can ask? And also, how can you check where it got the answers from? I think that's even more interesting, because you don't want to end up on, any weird dark web website where it talks about, I don't know, inject this and that, or eat 2 aspirins and your tumor is gone. Really need to understand how can you then tailor it to where you get the answers from. So maybe going forward, something like a dedicated ChatGPT for PubMed also, or for all these guidelines might be of interest. And you also see that with all the publications coming out, some of them supported by AI to generate them, it's completely fine if they are validated and you have the data, but you need to be able to read that. And even for me, it's difficult to catch up with what's currently published. So getting these summaries, getting maybe daily updates. Okay, there's this new publication out. Somebody tried something else. All of this we need to incorporate. The inflow of information dramatically increases right now. You need to be able to handle it. So to summarize this, you need to really be able to understand how AI works, that you can prompt and basically ask the questions. You need to understand how I can understand if that's really a valid answer that I can further on use. And then potentially use like agentic AI to get even more information, more top notch. How can I keep up the speed at this point?
This is fantastic. And Alex, excuse me, I appreciate that question, because it feels as if a little bit of a shameless plug, because our department, myself and Dr. Maloney, recently working with the Department of Medical Education, just launched our new Pathways program called the Doctor of the Future. And these are some of the things at the University of Miami. This is why I'm so proud to be here. We are thinking about, not just thinking, but acting. So it's not just about being thought leaders, but action leaders. And I love what you just said, Dr. Brost, about, being AI native doesn't mean that you use AI, per se only. It means that AI, you think AI first, just like how you gave that analog with phones, right? So with that, thank you so much. for a phenomenal talk. And as Alex mentioned, that, same time next month, we'll have another phenomenal speaker, courtesy of the Department of Informatics and Health Data Science. Dr. Brost, as well as some of you, all of you who have joined, thank you